Hi, everyone. Good morning, good afternoon, and thank you for joining us today. We will begin in exactly 60 seconds at 12 noon. Again, I want to thank you for joining us. So welcome to today's webinar, Telebehavioral Health Services, Planning and Investing for the Future of Your Services. This is session 2, the evidence base for telebehavioral health and digital mental health services with Jay Ostrowski. Next slide, please. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC. We're housed at Rutgers in the School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kathy, and I'm the project coordinator of the center and will be facilitating this webinar today. Just a little bit about us. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health and other related workforces to deliver evidence-based and empirically supported practices to individuals with mental illnesses. Please visit the MHTTC Network website for additional information at mhtcnetwork.org. Next slide, please. And if you're interested in staying up to date with the events and products that the Northeast and Caribbean Mental Health Transfer Center is providing, we ask that you please sign up to receive our email communications. You can sign up at the bit.ly link provided on the screen. Next slide, please. Following the webinar, you'll be asked to complete a brief survey, and we value this feedback and use it to improve our activities and inform future activities. The surveys are also important because our continued funding is linked to the completion of these surveys. So we thank you in advance for your feedback. Next slide. We also want to let you know that this webinar is being recorded and will be posted to our website along with the PowerPoint slides in the next few days. Next slide, please. This presentation was prepared for the Northeast and Caribbean Mental Health Technology Transfer Center under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. All material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. Citation of the source is appreciated. Please do not reproduce or distribute this presentation for a fee without specific written authorization from the Northeast and Caribbean Mental Health Technology Transfer Center. At the time of this presentation, Tom Codir served as Acting Assistant Secretary for Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. No official support or endorsement of DHHS, the SAMHSA, for the opinions described in this presentation or is intended or should be inferred. Next slide, please. We encourage you to interact with our presenter during this webinar by using the chat feature. Please post any questions or comments you have in the chat, and I will collect your questions as we go and ask them of the presenter during the Q&A time towards the end of the presentation. During the webinar, our presenter may pose questions to you, so please use the chat feature to answer these questions. Next slide. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. This includes language that is strength-based and hopeful, language that is inclusive and accepting of diverse cultures, genders, perspectives, and experiences, language that is healing-centered and trauma-responsive, language that invites individuals to participate in their own recovery journey, language that is person-first and free of labels, language that is non-judgmental and avoids assumptions, language that is respectful, clear, and understandable and consistent with our actions, policies, and products. Next slide, please. Now let's begin our webinar. We have Jay Ostrowski with us today. Jay is the CEO of Behavioral Health Innovation, where he develops and deploys telemental health, telebehavioral health, and telemet programs and designs HIPAA-secure software applications such as adaptive Telehealth. He also serves as a telehealth consultative and implementation partner for the Mid-Atlantic Telehealth Resource Center and is the director of the Telebehavioral Health Center of Excellence. So again, we welcome you all, and thank you for being with us today. And I'll turn it over to Jay.
Thank you. I appreciate you inviting me to do this again. And this is a second part of a longer series. So we'll be recapping a couple of things from the other presentations and then adding kind of layers and information as we go. So I hope you enjoy that. Also, we're very interested in hearing your questions to make sure that we tailor this to fit your needs and expectations. So feel free to type something in the chat. Fun fact, I hold open office hours every other Friday for about 2 hours. And this coming Friday, I'll be doing that again. So you can get that link at the MATRC URL that's on this page. It's at the home page, center of the screen. Click on the button and join me there for about 2 hours just to ask and answer random questions about telehealth. So before I begin, I just want to give you quite a little bit of context about me and where I get this information and how I use it in myself. I started in telehealth in about 2002. I'm a licensed professional counselor, licensed supervisor, and I was asked to see a little girl who was about 10 years old in Indonesia. She was part of a missionary family that was deployed to the field, and about a month into it, they called for help. And I was able to help this girl through video. It was a grainy video. It was dial-up, and it was quite sad experience compared to what the good stuff we have today. But it got me excited about doing telehealth, and I saw a lot of potential and a lot of problems at the time. There was no ethics, there were no laws, there were no reimbursement. It was really kind of winging it. We've come a very long way. And at the same time, I didn't know this, and most people still don't know this, that the Department of Defense and the Veterans Administration had been doing quite a lot of research, creating a body of knowledge and efficacy to do that and experience. So we have a lot to build upon that, and even today. Then the pandemic has hit. The world discovered telemedicine, and suddenly people are popping up, saying it's the greatest thing, which it is the greatest thing. However, there are some cautions and some caveats to do that. So I'm also kind of a critic in one sense, where I help make software and I help make these programs, and one size doesn't fit all for telehealth. So when you see efficacy, you have to see it within the context of how they deployed it, and that there are differences, and we'll talk through that. And then we're going to go through some of the evidence of other types of things and kind of what's ready and has a lot of evidence and what doesn't. But I think we'll be emerging soon. So buckle up and we'll get to it. So what we're going to do here in our objectives is to talk about the efficacy and really give you a little bit of critical eye of the data. We're going to talk about services that are, again, ready to deploy, and then talk about where there are some challenges and opportunities also in the research. So what is telebehavioral health? If you ask 10 people, you're likely to get at least 8 different answers, because telebehavioral health is now used very widely, especially by SAMHSA and others, as kind of the catch-all for all things telehealth that are related to mental health and behavioral health. And I'll break this down in a second. But broadly speaking, it's any service that we're providing through the internet at a distance, or through technology at a distance. So we're using it today as a catch-all. I may use interchangeably telemental health or digital health. I'm broadly meaning the same thing unless I'm talking about a specific service or type of service. My first published paper in 2015 was on the names, because at that time I researched all the laws in all the states for counseling, psychology, and social work, and found 26 different terms for the same concept here of telebehavioral health. Now we're up to more than 48. It's 48 exactly, actually. 48 different terms used by license boards, and there's even more in the open internet of what people call this. That's because people keep inventing new names. Some of it because there are new services, some of it because it sounds cool in a dissertation, some of it because they're just trying to think more broadly about things. And that's where a lot of these names kind of pop up. But when we want to talk about that as a group, we typically kind of narrow it down to telebehavioral health or telemental health or digital services, something along those lines. But you can imagine what it's like doing the research for this when everybody uses different terms, and Google and the Scholar websites are not great at matching all the terms yet. So it might be taking a while. So if you're a researcher, we'd love for you to use telebehavioral health as your keyword, or even the word that you use most often. So want to put this in the context of telehealth in general. So telehealth is kind of the broader term for healthcare at a distance, or healthcare through technology. It's kind of hard to do it at a distance without technology, of course. I won't go into the details of that, but it's a long conversation if you want to have that with me on Friday. But we tend to look at all the things on the left side of the screen is more ambulatory. So this is your medical doctor, and then of course a psychiatrist is a medical doctor as well. But we put them on the right-hand side under telebehavioral health, and we distinguish. When we talk about medications, we'll talk about telepsychiatry specifically, and then telemental health for more the counseling areas. But we would also put under here clinical apps and even case management as part of our telebehavioral health kind of suite of terms that we'll use. So I'm both a practitioner and a creator and a subject matter expert on this. So when I look at the research and the options, I tend to boil it down to 4 different buckets, because I like to simplify things. But the first text-based is things that are through a keyboard, and they're typically this is typically an asynchronous or almost real-time synchronous chat, live back and forth typing back and forth with people. And this actually does have some efficacy. We'll talk more about that in a bit. But this is everything kind of you would do on a keyboard. Now, this was basically the first type of telemental health when the internet first became ubiquitous, when everybody was doing dial-up with your 28 bits or kilobytes of data going back and forth, because video wasn't viable early on. So we were doing some kind of texting email-like therapy back and forth. And then that's, of course, has evolved over time to almost real-time chat or messages. So now the lines get blurred in that we embed these text-based things into an app or alongside of a video, or put them in a forum, or put them in a clinical workbook. So text-based is kind of the bucket of how you do that. And I'm going over these buckets because the research has these buckets as well. And it's important to distinguish the efficacy is stronger in one case than another. And we don't want to basically overstate the efficacy in one way or another. We want to be clear about that. Also, the part of this to understand, if you're looking to invest in this or grow your services, that quite a lot of the efficacy is tied to how it's implemented. A lot of people kind of go into this just doing their best, and they learn a lot of lessons along the way. And so their research project, they don't know what they know until after the fact. And so sometimes the research results are a little skewed because of different factors, like how people were onboarded or implemented, even the technology that's used, the cadence of the therapy, the type of therapy, and how good the therapist was in general. So we'll come back to a lot of our research, though, is kind of the aggregates of many studies, meta studies. So we want to look at text in general, and then think about it in the context of how we would use it in apps and other places. And then apps itself, CCBT is computerized cognitive behavioral therapy. CCBT has been around for a while and well studied. Apps are kind of the new, more fashionable way of presenting CCBT. Just in this way, you don't have to download something onto your laptop or desktop, as it were, back in the day. But it's an app, either a cloud app or a one that's on your smartphone. And these, of course, could be could be embedded with several other types of functions as we make them with multi-features. But when we're thinking about the apps themselves, the data about the apps is closely tied to the app itself, how well built it was and how user-friendly it is. And so when you're looking at this, are you measuring the effectiveness of how well they built the app, or the treatment within the app, or treatment delivered through the app? So it's hard to know, which thing you're measuring sometimes. And then there's video. Video has a very strong user base, and of course, over the last year and a half, the evidence has grown dramatically stronger. And then, of course, avatar. And when I talk about avatar, this is your kind of cartoon-based, or your kind of an overlay. It could be a virtual reality sense, or like a kind of like a cartoon movie, or like a Sims, or think of Minecraft, but with you as the character and somebody else as their own character interacting with each other. Or it could be virtual reality, augmented reality, where you're putting an overlay of another image on top of a real world experience. So there are different types of things that can be explored there as well. And there's some research behind some of those. I'm conscious of time. We're not going to be able to do everything and talk about everything. So please do give me your questions in the chat, and you can message me privately if you want me to send you some research on that later, or want to meet with me in the open office hours on Friday. But I'm happy to give you, what we have on these different modalities if I don't hit exactly what you want today. So know that there are basically 4 big buckets that we're putting our data in. And then underlying that, I would add artificial intelligence. So artificial intelligence doesn't really go into one bucket, because it really could empower all 4 buckets, and create kind of its own engine behind all of these buckets. And we'll talk about some of the research there, and some of the promise it holds as well. As we look at these things, I want you to consider how they could be used. If you're not experienced with them, it's okay. They have all of them have their own use cases where they work well, and use cases where they don't work so well. So the effectiveness of this could be closely tied to your use case, and again, the technology you used, and kind of the onboarding of that. The strongest evidence that we have to date is more in this clinical video space, and we've been using this video for almost 20 years now, and there is a very strong evidence for that. But again, as we talk about the good evidence for it, we're going to show you some of the data. A lot of that has to do with the experience of the client and of the provider. So if the provider feels like it's clunky, or the client doesn't like it, or they can't connect well, their satisfaction rate and their therapy, their objectives that they're meeting or trying to meet, are going to be influenced by that. So if the technology is a mess, it would be equivalent to having an office where there's a lot of loud noise around. A physical office with, you can hear someone's therapy in the next room where they're doing maybe anger expression, and it's really loud and it comes through the walls. That would disturb the client in person. Same thing with this. If the experience they're having in this kind of digital office space is not well done, then that can be a factor that influences the outcomes. So when we're looking at telehealth, notice that I keep talking about 4 buckets and 4 different ways of doing this, because the future of mental health is really in using multiple venues at the same time. I know some of us are still in the arena of fee-based, where we're doing a certain amount of session time, and we're paid for our time. Others of us are in a capitated world, where we're paid for outcomes. We're paid for the entirety of someone's care, and that's where using multiple modes makes even more sense. Although you can get paid in some venues for some text-based work. But you think about this for a moment, that our population growth is growing exponentially more than we grow providers of all types. So we have to, as a society, find ways to leverage what we're doing to make sure that we get a better reach, for better access to people to get more care, so that we get more more help spread around. So our limited provider time might be spent doing some videos, some secure messaging, some prescribing of modules, and even using some specialty apps as part of our treatment. So we want to lead people to the least level of care possible, because we have more people that need care than can get care. So some of it, if you have open office hours right now that you don't have appointments, I would say that's probably a misdistribution right now, and we need to find out how to connect you with the clients that are looking for help. So one of the things I also want to talk about here is the app itself. So apps are quite helpful as an augment to therapy. We have many things that can be used in this space, like community connection with other people in treatment in a confidential way, or self-help resources to give them reminders, maybe notifications of appointments and things that keep them motivated or up to date on their treatment goals, or contacting their sponsor or provider. And even location alerts where you can geo-fence hotspots where someone maybe has trigger points, maybe a bar or place where they would get something, and that alert can alert our sponsor or them to remind them of their treatment goals and what they're trying to do. So these are just kind of different innovations, and all of them have very different levels of success rates. So I just want to kind of put that out there while we're talking about all this. One of the best ways, I think, of using apps is this kind of triage way. It's a way to kind of filter people to the right level of care. And this is an example of an app that was made for that, where it's just asking people periodically, how you doing? And if it's not so good, they'll get a response back to say, great, would you like to look at some kind of motivational content? And it fits some of their pre-met content interests. Or hey, you're not doing as well as you could be, and it goes through kind of an algorithm of asking them more questions, like a kind of a live chat bot. And it's giving them, do you want to do an assessment? And maybe they were superficially bright, and now they really want to get more help with what they're talking about. And they do an assessment, maybe a GAD-7 or a DAS or a PHQ-9, depending on what's preferred in this scenario. And then basically leading them through this kind of live interaction with them, but through a robot, to say, do you need live help, or do you want to chat with somebody, or do you want to have a video appointment with somebody? So you can think about this as kind of a tool for triage. This specific algorithm has not been studied. These are things that are lacking from the research. So it's part of my evidence base that I want to tell you about, is that we're lacking evidence on some of these kind of cutting edge innovations that really extend care. So if you're a researcher, this is where I think some of the work should be done. This is just a little bit more color and flavor on a triage system that we built recently for the country of Australia, where they're going through a DAST screening, and from that workflow, it would lead to a library of like video and text content, either treatment content or kind of motivational relapse prevention kind of content, or to go to kind of a chat or a workbook for self-help, or to a video meeting, depending on what they needed. So what does evidence-based mean? Some of you are in academia and maybe would say this more eloquently than I would. My bachelor's is in experimental psych. So, and then I have a master's in counseling psychology, and I've always been interested in the testing and measurement experimentation part. I find a lot of apps out there are labeled evidence-based, and that has no magic meaning to it. It's kind of like the word contract or the word HIPAA compliant. One size does not fit all. It means different things to different people depending on how much they applied something here. So evidence-based could mean that it's a bunch of software developers that took some cognitive behavioral therapy ideas and put those ideas into an app, and then they would call it evidence-based. There are other people that might take offense to that and say, hey, you should directly study the app itself and find out what's the outcome of using this app. And so when you're looking at the research, the meta studies that we're going to talk about include all of these different modes. There are these evidence-based apps or evidence-based treatments, or some of them are specifically researched. And I mean, it takes quite a lot to parse out all of those. We have some of both that we're going to talk about. And I can give you some of both if you reach out to me. So I just want you to understand the quality of the data that we're talking about so you can be a good shopper. And then when you see brand names out there that say, evidence-based, you want to dig in and find out what they actually mean by that. Do they have actually clinicians on staff that are creating the content, or are they working with a university or a team? Or are they getting it from Quora or Wikipedia? We do find all of them out there right now, and the nice polished websites, it's hard to tell what's what. And even in the research out there, it's hard to tell from PubMed and other research bases how this was created and how it was used specifically. So with that kind of vagueness in mind, the aggregate of all the data, though, does support telemental health and does support telebehavioral health, or we wouldn't be doing this webinar, of course. But I want you to be kind of aware of what that looks like. Another pretty popular way to study this is to kind of have a look back at medical records and say, okay, these people that came in and did in-person care, and these other people were using an app, and overall, how did their treatment progress over a year or 2 years? And maybe their PHQ-9 went from XYZ to ABC or vice versa. And that's kind of the quality of some of that data is more retrospective looking. And I mean, the best research we could do would be like a double-blind study with very clear objectives and goals and clear measurements. Those are just lacking in a great measure in the data from my view. Some of them are done well, but in aggregate, there's not a lot of great data out there because they're kind of more what I would say off the cuff kind of studies, except for some of those I'm going to show you that are very strong. So over the data that I'm describing is more of the last couple of years that we've seen. In the pandemic, there was a rush to publish stuff. And there's a lot of people publishing studies on here's what it was like for us to do. And it was efficacious. And sometimes they're clear about efficacy and sometimes they're not clear about efficacy. But again, the good news is on aggregate and some very strong individual studies are very strong pro telemental health, stronger more in the video space than the text space, but the text messaging space also has pretty good results as well. So a couple difficulties with the terms, sorry, with the research. One I already mentioned was the terms. When you're doing research, finding this information is tricky sometimes because people use these different terms, and sometimes they're not found because somebody used a new novel term. So again, we need better keywords. Another one is the types of care that we're doing. It's not always clear exactly the type of care that they're doing through these apps. And then the data can be, really varied in terms of what we're collecting and what's influencing this collection. So the purest scientist to me would like better measurements and better data. But even with that, we do find some really good evidence that's been revalidated over time. My favorite study, though, is this newer one that came out by some friends of mine, actually. Don Hilty led a team. He's a psychiatrist and telepsychiatrist. And this is a comparison of in-person, synchronous, and asynchronous telepsychiatry. And his findings were there are no findings. So I thought that was my favorite study I'd share with you. So if you're looking for a new thing to study, they would like to see, and we would like to see, a comparison of people doing text-based psychiatry and text-based video telehealth versus in-person care psychiatry. So if you're a researcher, that's the next frontier because we need to find a way to scale psychiatry. So now to the real data, the reason you came to this webinar. I want to give you 3 really strong studies that are a little bit older, but they're also very strong studies. This first one on the left side is a study actually done a few years ago, and it is to me, this is the landmark study of telebehavioral health. And I'll go to a different slide. We're going to focus on that a little bit more. It's almost 1 million veterans and a very strong data set. The second one is, a another strong data set of about 12,000 substance abuse facilities. And then the third one is specific to telepsychiatry. And all three of them showed very significant outcomes. So the patients were reaching their outcomes. The clinicians were satisfied, the patients were satisfied. And it basically is a great outcome on many ways. And this is a combination of telepsychiatry, counseling, individual and group therapies. So the right side one, the American Psychiatric Association, was focused more on telepsychiatry for anxiety and PTSD. This middle one, the treatment was more on substance abuse. And then the Veterans Administration, it was all types of therapy. They didn't really distinguish what type of therapy it was for. This is that landmark study that I mentioned, and basically they collected data between 2003 and 2013, and there are actually different versions of the same data set. So this is one version of it that talks about this, but they basically found their visits growing and growing and growing. You can see the kind of the growth on the top right hand side, and they were reporting on just basically, here's all that we've been doing. And what they found is a 25% decrease in hospitalizations because they were switching people to telehealth. A lot of this is because of the majority of veterans actually live in rural areas. And they were finding that there was this increase in suicide, this increase in drug abuse, alcohol abuse, and they were finding that these people were not getting into treatment, or they were not getting to treatment frequently enough to get the outcomes that everybody would hope for. It's almost impossible to do 90 meetings in 90 days if you live in a rural area and there aren't really AA meetings around, or NA meetings around, or any kind of treatment like that. So and also the longer someone has to drive to treatment, the less likely they are going to go to treatment. So by doing telemental health, telebehavioral health, they were able to see many clients in their own homes. And if they didn't have good, strong internet access, they would basically be seeing them in a local clinic and do like a clinic to clinic work. So this is a combination of individual and group meetings. Most of them were basically the introductory calls where they're doing the screenings, and then the follow-up therapy as well. They had a very high satisfaction rate. So you know how surveys go, you don't get all the surveys back that you want, but they got quite a few surveys back and found a 94% satisfaction rate. They also, I didn't put it here on the slide, but they also found a decrease in no-show appointment openings. So that is also a kind of a good use of the provider time, right, to have fewer no-shows. So that's also very significant from a financial perspective. They had more and more people, jumping on the bandwagon back in the day. As you can see, a 10-fold increase in new patients annually. This is across a lot of clinics and a lot of medical centers. So this is, again, the most broadly based research study to date on telebehavioral health. And it basically very strongly, it's a resounding endorsement for telebehavioral health. So when I'm implementing this or talking to somebody about implementing telemental health, especially with providers, when I'm training providers, they're asking me, well, what's different and how's this different than in-person care? There are some things that are different and then many things that are the same. So I wanted to make a slide and talk about the research behind or the research that substantiates each of these things. So when we are talking about doing work online, a lot of people are comparing it to in person, and the research is very strongly shows that it has as good of outcomes as in-person therapy. So the research again shows as good outcomes as in-person therapy, and that means they're meeting their treatment goals. Their symptoms are reducing at the same rates for the same conditions. So that's really promising and really good news. When you dig into the research more, you find a couple other things that are pretty interesting. One is that the patient satisfaction of the earlier studies is really high. The provider satisfaction, not so high. It's not low, but it's kind of meh. And I think a lot of that is we as clinicians prefer in-person care. And one of the recent studies that I just read from this past year was showing that this rapid deployment of people into telemental health from the pandemic was really an interesting kind of study. And majority of people that had some tech experience and some experience with video felt pretty comfortable switching to therapy, and said that they would be willing to continue doing telemental health. Those that were not so satisfied were both patients and practitioners, providers that were not as tech savvy, and had a little bit of anxiety of, is this effective? Can I really bond with my clients? Can we really do this? But the majority of them, after they've tried it for a few sessions, have found that they really could do this well. So I think that when you're wondering, should we deploy this with our team? Should we scale this with other providers? The providers that are not used to video or not used to online venues, they just need a little bit more training, a little bit more experience. And that experience will correlate with better outcomes. And there's actually clear research that shows when the provider is comfortable with the venue, that is mirrored in the client. And when the provider is not comfortable, then the client also is not comfortable and doesn't meet their treatment goals. So that's a kind of a corollary of if you're going to take this research and do something with it to expand your care, you need to have some training and implementation methods. It's not just, hey, start using this. So that's actually across several different studies. I found that people that rapidly deployed over the last year and a half because of the pandemic, the key need there, the key takeaway from everybody was, we should have had standards in place. We should have had training in place. And with training and standards, we all can do pretty well with this. There's also protocols that they also needed for onboarding both the providers and the clients. So efficacy is the same. So there are some caveats to this. One study that I'll note here is when treating PTSD, there's a study that compares in-person PTSD exposure treatment. So exposure treatment is where you're helping the client address the exact challenges that they have. It's a PTSD. Having PTSD, you often will start avoiding things that remind you of the trauma you've had, or maybe you stop going places or start kind of isolating more. And the exposure treatment would slowly have them face those challenges and basically habituate and accommodate them again to kind of restore their functioning. They found no treatment outcome differences between in-home, in the office, and online. They did, however, find there's a higher dropout rate of the online version of that than the in-home version of that. So I think that's also the same kind of data we get from apps. We find there's some efficacy in using apps, but there's a higher treatment dropout of apps because I think some apps haven't figured out how to keep people engaged longer term to get the outcomes they want. And I'll come back to that in a bit. So we also use the same methods. So there's no kind of magic in the therapy that we do. I would say it's about 95% the same. There are some things I do differently as a telemental health provider because I'm not in person and I have the screen. There are, however, quite a few things that they should be doing before their session and at the beginning of their session, and basically bookends around the session to make it legal and ethical and secure. So it's not just pick up any video and get started. With the pandemic morphing, I would say, I wouldn't say it's ending, I'd say it's morphing. They are relaxing some of the restrictions. They are coming back to the restrictions of HIPAA compliance and kind of telemental health standards that were kind of abandoned about a year ago. So there are ethics, there are laws in place that we need to be abiding by, and some states are reinforcing those. And so if you're implementing these, just keep that in mind. One of the things that concerns me about the recent data is that we're not measuring in the time of those standardizations. So I think some of the research might be a little bit skewed over the last year because we were onboarding in a different way and using it in a different way than we normally would. However, in the way we normally would, it still has very high efficacy. So the same methods by that are like CBT and rational motive therapy, or exposure therapy. Any type of therapy you would do online, you can do in person, you can do online. Also, there have been quite a lot of cool adaptations using play therapy for children, and it's beyond the scope of here, but they are finding good outcomes with play therapy even through that. Actually, some preferred methods, the research supports like parent training. And this is something that we did early on, maybe I think almost 10 years ago, where we have a Bluetooth headset in a parent's ear and a camera on the child in their home, or no camera, and just a therapist or parent coach coaching the parent on how to modify or address certain behaviors. And only the parent can hear the provider talking in their ear, coaching them on the right things to do. And they found that kind of interaction was highly effective way to extend care and keep the care in the home. So we do use the same methods. And again, I have citations for all of these. If you want the slide deck, it'll be at the end of the slide deck for all the citations you need. And then we use the same services. So the same services we would do for in-person, we're doing online. That includes, like bedside consultations in the hospital. That includes remote IOP, intensive outpatient. So before the pandemic, there were several third-party providers that were, third-party insurances that were paying for remote intensive outpatient therapy. So that's basically group therapy on the internet. It would be a provider maybe at a hospital doing some in person and being basically recorded on video or live stream video while there were people in remote areas, participating in the treatment, and they would be on camera, participating by voice, back and forth with the group. So it's not like it's a bunch of blanked out faces on Zoom. These people are on camera, engaged as much as the therapist would engage them in person. So those are the kinds of services that we were doing, in person. We're doing those online, and they are effective. But those would be done. I would qualify that to say they're being done through video, not just through text or any means. So you'll hear that I'm kind of careful in saying which venue. So also the same clients. You might say, well, not everybody's going to be good at this, and not everybody's going to want this. But we have to date, there's no contraindications found in the literature for telemental health or telebehavioral health, meaning there's no diagnosis that we found should not be treated. That doesn't mean that we've proven every diagnosis can be or should be, but there are to date no contraindications where someone has found negative outcomes or somehow it harmed the client. Most often we'll find that maybe it didn't have as high of efficacy as another mode of therapy, but most often we're finding the rates of efficacy equivalent to in-person care for the majority of the data that we're collecting. Another caveat that I think is important to note is that we are seeing critical patients they're highly acute, that are suicidal, homicidal, even doing remote, remote ways of helping them and get emergency services or even hospital commissions. So effectiveness in the research is again strongly supported by the couple of studies that I showed you. These are a couple of additional meta studies that I've pulled out that I like to show. This one's of 92 studies, another one of 148 studies. These showed positive outcomes meeting their treatment goals, high patient satisfaction, and as I mentioned before, the moderate to high clinical satisfaction. Apps in telebehavioral health have kind of a mixed review. So I would say on the majority of evidence, their apps can be effective for telemental health, for helping a client reach their treatment goals. But there are so many different ones and so many are novel that it's hard to extrapolate to all of them. So what we do is we go back to the evidence-based idea and say, hey, we're going to do something that has strong evidence like CBT, put it in an app, and then study, outcomes. We found some, positive outcomes from that, but not as much as the evidence is not as strong because we can't always tell what we're measuring. Is it the onboarding, the patient experience, the therapy, or the therapy mode of CBT? But I would say if you're looking to invest, this is a place to invest and to plan for, because there are so many ancillary benefits to keeping the patient engaged, the client engaged in the treatment, reminded of the treatment the goals, reminded of their homework, reminded of their appointments, that HIPAA secure apps like that are a really good idea. Unfortunately, there are a lot of the word HIPAA is used too loosely, in my view, where things are not as HIPAA compliant as they should be by app makers. But there are some really good apps out there, and some apps I can send you to that the DoD made that do have good evidence as well. I wanted to give you a study showing CCBT. This is the first app that I made, not the specific one, but I made a insomnia app about 10 years ago with a group of people, and it was chosen by a Harvard MIT work group as a treatment of choice, and partners picked it up, and Blue Cross Blue Shield picked it up because we found very strong evidence that people can do this kind of self-help CBT to get a reduction in their symptoms, and also reduction in like Ambien and melatonin and other things by just helping themselves reorient their thoughts and their mental habits into better places where they had reduced anxiety and were able to sleep more frequently, more deeply, more often. And so we found that CCBT can be highly effective, and we need more of these kind of apps as well. I think we'll see a lot more of those as we're trying to extend care and have people do more self-care in the future. Chatbots are also rapidly emerging. This is a study done by the app maker, so keep that in mind, where they found a 20% different reduction in symptoms for PHQ-9 symptoms over a 2-week period. So this is promising work, and we make apps very similar to this. My concern with these apps is that the data is being sometimes used by services that's not protecting the data in a HIPAA secure way. So we just need to keep an eye on that and make sure that patient data isn't going into Amazon or Google algorithms, and patient data isn't going out into Google in general and the internet. So, but the apps themselves, if properly made and designed, they are a good way to engage clients. And this is a little bit tricky as someone that's looking at this. You might think there's no way I would talk to an app like that. But we're finding that actually veterans and other clients will do this. They will do these treatments. Again, it's not everybody will, but there are some sub segments of the population that are fine interacting with a bot to help them kind of get their mind in gear. In fact, some of them prefer it and even prefer the video venue and the text venue over the in-person venue because it feels less intense for them, and they're able to share more. There's also a very well-researched effect called the disinhibition effect. So they are not inhibited by sharing more in this space. We find that people will share more with a computer screen than they will with someone in person. So they'll disclose more content and more what's considered sensitive content than they would to an in-person therapy session. Avatars and the use of avatars and virtual reality, augmented reality are growing. There is a little bit of evidence that this can have some positive therapeutic effects. It's not widely used right now. It's not in a place where it's easy to deploy as much as it could be, but we expect that it will be. Soon. Some of the avatars are done in a couple different ways. Some of the avatars are computer programs, AI talking to you. And the DoD, the Veterans Administration, have been using one similar to what's on screen to interact with clients, asynchronously, right? So it's the computer AI talking to the client, not asynchronous, but in real time without a provider involved. There's another type of avatar therapy where the provider is actually behind the avatar itself, and they're representing a part of that client. So in this screenshot here, the client is struggling with schizophrenia. And what's represented on the screen is the avatar of one of those voices. And so the provider worked with the client to modulate the voice to be about the same and the picture to look very similar to what this this patient thinks of when they think of this voice. And basically they have a conversation. So it's kind of manifesting what's already in this client's head. The provider knows enough about what those voices in the guy's heads are saying, so he's able to kind of interact with them, and then the client is able to kind of outwardly combat the thoughts, combat the voice with the therapy. They're basically able to use that therapy by personifying this voice on the computer. There is some a little bit of evidence that this has some legs and could be more of the future. But again, it does take a little bit more to set up and get going. Artificial intelligence. So this is funny. When I'm typing a slide about artificial intelligence on Google Slides, you'll see the red circle on the screen. As I was typing, Google decided to go ahead and the Google artificial intelligence decided to go ahead and help me finish my sentence. So I thought that was pretty funny. So I took a screenshot of it and put it as this illustration of right now, AI is being used and you have used AI and maybe didn't know it. So every time you're Googling something and you see the word, the little grade filled in, or using a doc or something like that, and you see that little extra phrase that's filled in for you, that's artificial intelligence. They're tracking what you're typing in and they're predicting what they think was going to happen next. And you can just click enter and it shows up, or tab, and you have that, or you keep typing and it's something else. But this is already in place and rapidly growing. Now, there are some problems with this, and so we need to keep an eye on it, but there are some many good benefits that are really going to help us. So they're being used in some electronic health records to kind of say, hey, people with these symptoms and these parameters usually need these other things. Some of them are used in mood rating scales or brain imaging, finding tumors and abnormalities. In fact, studies show that they can find them better than the radiologist in many cases. Also creating some monitoring systems and monitoring social media platforms. And we have a study we'll come back to in just a sec on that. Artificial intelligence does not have a strong evidence base at this point, but I want you to raise your awareness because it soon will. The tricky part of these ventures are that they're difficult to make. We've made some already, and they're not easy to make, and they can include different biases that can take it way off one way or another. AI is basically can create kind of a living being, almost an algorithm that continues to train itself, and then garbage in, garbage out. Or if you train it a certain way, it may not cover other things that might be missing. So there's a lot of data science that's needed to do this, but it can do quite a few things by predicting something or preventing something, early detection of different things that are happening, by basically collecting data and collating that into a profile and say, hey, you're meeting this profile of people that have these, that do these things, say these things, have these presentations, typically have these outcomes. And that means we can early identify and, but also and keep treatment at a lower level of care if the patient's compliant, or the client's compliant. It also helps us research and learn a lot more about what works and create some treatment remedies that don't need a provider, and help us as providers focus on other places where we are very much needed. Apps and telehealth can't help clients on their own for 100% of the time. They can help augment care, but to date, I wouldn't say it's a replacement for care. AI has the potential to replace some forms of care, probably not all forms of care, but I do think it's a place for now for raising people's awareness of symptoms and helping find correlations and early identification. Before we end, I want to show you a couple of places we can apply this. One is identifying behavior trends and awareness of things, like I said, for early intervention, tracking how we're doing as clinicians, and basically rating us, giving us feedback and even options and ideas for treatment that we maybe didn't come to because we're tired or we just didn't see something from a certain angle. It can also be helpful to simulate client behavior so that we can actually practice doing treatment with a AI or with a chatbot, and providing good feedback loops to it. And there are much more that we can do, but I just want to give you some examples. I want to end with this quickly, and I want to answer a few questions here. This is actually a study that was released December 14th, 2020. And it says, what if we could predict that someone would develop psychotic symptoms 1 to 1.5 years ahead of a clinical diagnosis? That actually happened. So basically, Facebook partnered with and got permission from a data set of people and started measuring what their text messages were saying, or their instant messages, and what they were posting about. And by analyzing this data, over time, they found that a certain percentage of these people, about 200 of them, were predicted to have some kind of psychosis or psychotic diagnosis, and that in fact came true, and they were diagnosed and verified as diagnosed. That's a very powerful tool. However, it comes with lots of ethical issues and questions about, like, it reminds me of the Minority Report movie where we were the Tom Cruise and them were going and intervening right before somebody committed a crime, and they got arrested before they committed the crime. We don't want to go that far, of course, but I think this shows that there's something we can do here with permission, of course, and with good ethical guidelines and boundaries, that maybe we could help people see themselves and maybe help them steer onto a better track before things get too far afield. So I want to answer a few questions here, but I also want to give you a little gift. Remind you that this Friday from 12 to 2, I'll be doing grant funding technical assistance. If you go to the MATRC website, matrc.org, in the middle of the page, there'll be a link on my open office hours, and you can see my face there, and click it and join me to ask me some mental health questions. So with a little bit of time left, I'd like to answer some of the chat, and you're welcome to send me more questions here, and I'll try to answer them. If you want to put your email address, I can answer them later today or on Friday. So first of all, I want to look here and say, Katie, did you see some questions that you wanted me to answer quickly?
Not at this moment. We are, like we had mentioned, we are in the Q&A portion of our webinar. So we also have a function that if you'd like to raise your hand, we can unmute your mic if that's more comfortable for you. So I think maybe some folks are typing in their questions. We have a lot of positive feedback, so thank you for you, Jay. So.
Oh, great, thank you. Also a reminder, if you haven't done it yet, please do us a favor and go ahead and click on the link in the chat to fill out a survey to let us know how we're doing, so that we can tailor this to be better for you. And it also helps with the funding as well, to make sure that we can keep on doing these programs.
Thank you. If you could please advance the slide deck to the QR code, please. There we go. So as Jay had mentioned, we are a federally funded technical training and assistance center, and as part of this funding, we're required to submit data related to the quality of this event. So you can either use the QR code that you see on the screen, or I will re-enter the link so you can access the evaluation survey. So I put it again in the chat. So we have a question by Wiley. So how does the free consulting work?
It actually is as it sounds. It's free, and it's technical assistance consulting. So we have a consulting firm, Behavioral Health Innovation, and that's been contracted by the Mid-Atlantic Telehealth Resource Center to provide free technical assistance up to 10 hours per entity. So we're also providing that free consultation service on those open office hours. But if you need, additional technical assistance, we can meet with you one-on-one and talk about your scenario and help you, talk through what you would need for your service to either start or scale or modify or experiment with something new. We can help you with what are the laws or the ethics, what are the trainings, what are the technologies, what are the best practices, what are the lessons learned, things not to do. We have quite a lot of experience to do that. And then if you would need more after that 10 hours, we can do contract work after that. But it is free and it's good stuff and it's tailored to you guys.
Thank you so much for your question, Winnie, and thank you, Jay. So we have another question here. Is there a list of apps, videos, or studies to assist primary care providers in offering CBT to teens?
I don't have a list primarily for primary care providers, but I hear you. How I would interpret that is that, you need CBT for teens. I would probably advise something like the Calm app would be a good start. And that's one I would recommend, or Mind, I think, is another one. There's a couple pretty popular ones out there that are well developed. But I don't have a particular list, but if you want to send me your contact information or join me on a call or click on the matrc.org site, you can ask a technical question for me and I can respond to you and send you a list of other ones for you to pass out to clients or patients.
Wonderful, thank you. So we are currently at the hour, exactly on the hour. And again, I want to thank everyone who joined us this afternoon in this webinar. Thank you, Jay. It was definitely very informative, especially with the new up and coming technology to assist providers. Again, I just wanted to reiterate, we will be posting the Zoom recording as well as the PDF version of Jay's slides onto our website, and that will be done within a week, as well as a certificate. So if we don't have any other questions, I think we look forward to seeing you next week at, next week at the same time, 12 p.m. Eastern Standard Time. And I will also, you'll receive a link to join for those who have registered for all of the sessions in this series. So I hope you have a wonderful day, and we'll see you next time.
Bye, everybody.
Bye.